these guys are. And he's not normally that fat. That's just a camera angle. Um, I, I'm hoping Flora might tell you at the bar later who they've decided will play me. I'm kind of hoping just a little bit of makeup should be fine, could do me, but I don't know. Um, but they've come across, especially from this last night, to come and talk to you today. And the first thing we're going to talk about. So the last couple of years, the team have talked about shock and hemorrhage, and we are going to carry on that theme now. Robbie and Sammy sadly can't be here this year because they've got family commitments, and they send their regards and look forward to seeing you again soon. Now, unless you've been living under a rock, you've probably all heard about the Reboa trial. Now, I don't know how much depth. Would anyone like to put their hand up if they've actually read the whole trial? So I'd actually say more people than I expected. Um, it's a big trial, and it's pretty significant, and it's pretty significant to our practice. So first of all, I have no declarations to give you, but a huge thanks to Robbie and Sammy for giving me the data to present on their behalf for this stuff. Now, we all know this trial, and interpreting the results, I think, is really, really important. And the key thing here is, if you look here, you've got Robbie and Sam's names there. So this take on the results and what the trial means comes from the authors. It's not a hot take by me. It's not a quick grab or an agendized thing. This is from the people that were involved in the trial and know it. So first of all, what is the trial? What are we talking about? What are we looking at? So it's a well-designed trial. It's a pragmatic trial. So it's looking at the effectiveness and evaluating the effectiveness of a treatment against routine care. It was multi-center, it was well constructed, it was multiple major trauma centers around the UK, and it was sequentially as recruited to with randomization. And I think the trial methodology can be seen as being fairly well constructed and robust. The inclusion criteria were someone with either confirmed or suspected life-threatening hemorrhage from the abdomen and caused by an injury, i.e. trauma, and someone that was amenable to Reboa. So again, pretty reasonable setup, pretty reasonable inclusion criteria. So when you look at the trial, I've paraphrased the wording from it, but what you're looking at is a comparison between standard care, which is what we are all doing every day, and because it's a UK-based trial, the care is fairly homogeneous between the major trauma centres you can expect, with some variation, the same sort of care to be delivered whether you are injured in Sheffield, London, Bristol, or wherever. There will be some differences regionally, but you're not expecting massive variations. And it's that standard care or standard care plus Reboa, and that group that we were talking about, uncontrolled or uncontrollable torso hemorrhage from trauma. And the endpoint was looking at 90-day all-cause mortality. Again, pretty reasonable, pretty sensible setup. So then what happened? So they randomized the first 90 patients, and they were enrolled, and the median severity score was about 41 and 46 for the group, so that was fairly reasonable. But one of the important things, when you look at this here, you see 46 were randomized to Reboa, 44 to standard care. That looks okay. But one of the key things here is only 19 of those patients randomized to Reboa actually got a balloon. And so that's the first sort of thing to think about when we're looking at this trial. So the intention to treat analysis looked at this and looked at the addition of Reboa, and with a good level of statistical evidence, they felt that the 90-day all-cause mortality for this group was higher, and therefore the trial was stopped first, stopped early. And that's the big headline that everyone's taken away from it. And that's entirely reasonable. And I don't think anyone's going to say that the methodology or those findings from the trial are wrong. It's about interpreting them in a wider context. But the key thing is to look at saying that those patients that got Reboa were only 41% of those randomized to Reboa. So what happened within that group? And what happened between the two groups? So when you look at their pre-hospital data, so the patient's pre-hospital characteristics, a pretty low systolic, that's not a million miles off, 11 versus 9. That's pretty reasonable. You can see why they were randomized that way and enrolled that way. Things start to unravel a little bit when you start looking at what happens to them in hospital. So time from injury to arrival at ED, 90 minutes, 97 minutes. Again, that's fairly reasonable, fairly standard within the UK. And then you look at the blood pressures for these groups. Now, this is where it starts to look a bit different. So the Reboa group, 41%, 18 out of 44 were below 70 versus 21%. And that's quite different, actually. Small numbers, very small numbers, but again, quite different. But the groups aren't that matched. And this is the other thing here. When you look at the abbreviated injury score, in the Reboa group, a reasonable number of those had head injuries and no one in the other group. And that's a confounder, and that's something we'll come on to talk about in some of the other talks. So the key things that I take away from this is that the groups aren't brilliantly matched. Now, that's not a criticism of the people designing the study or doing it. It's because the numbers are small, but it's reasonable on the evidence they've got to stop that study early. So what happened to the sicker cohort here, looking at the secondary outcomes? So the time from randomization to definitive hemorrhage control, 83 minutes versus 64 minutes. That's still a bit longer, but the sicker cohort seemed to be getting a delay to definitive treatment. Now that could be, and some people within the trial have said that's down to people attempting Reboa and failing Reboa, and that would make sense given that only 19 of those randomized to receive Reboa got it. So it's this skill of putting these Reboa balloons in and putting these arterial accesses into these really sick patients mean that actually it's quite hard to do and takes some time. And that's certainly our experience in London doing this outside of hospital as well. And so the sicker cohort got a bit of a delay and they had a bit of a worse outcome. That seems to, again, make sense and follow. When you look at the differences between the groups, the key difference between the groups. So they're all predominantly male, predominantly blunt trauma, so not the group that we see in London. The Reboa was, in general, put up about 2 hours post-injury. Now, 90 minutes to hospital is not unusual for our group in London when we intervene. But when we look at the time to intervention, 2 hours is probably quite long, probably too long, I would say. The time from arrival to randomization was another 13 minutes. Again, these delays are understandable, but the randomization to the hemorrhage control procedure of Reboa added on time to make it 83 minutes versus 63. And the median time to Reboa was 29 minutes after randomization. That's a long time. Sorry, the balloon was 29 minutes, which is not a long time, I should say, because the balloons either were deflated too early or there's a training issue about how they were used. And then again, when you look within the data, you find that of the patients that received, and remember only 19% patients received Reboa, 10% of those patients received a zone 1 Reboa and the remainder a zone 3. And 8 of those patients received a partial Reboa. So now the numbers get even tinier and what you can extrapolate from those becomes even less. But when you look at the trial, question is still there. Does the combination of Reboa and standard care, is it better than standard care alone for 90-day all-cause mortality? I think we can say from the data, it's quite obvious that it's not. When you look at a cohort that was a little bit more hypertensive on arrival and had a higher proportion of head injuries and a delay in intervention. I think once you put all of those things together, it certainly does start to explain why that group did worse. So if you want a more in-depth look at all of this data and the interpretations of it, there's this paper I would suggest you go to by Robbie and Max from the London and Ross Davenport from the London, looking at the promise of Reboa and specifically this trial. So I think we can all agree that when we talk about Reboa, doing it to a patient an hour to 2 hours post-injury in a centre that only sees a handful of patients doing this in practitioners that don't do this all the time probably isn't the right thing to do. So I think that's what we can take away from the trial. But what about for us at London HEMS? So even the highest volume centres in the UK only enrolled 4 patients per year into this trial. We would see those 4 patients in a matter of months in London in a much smaller group. So if you think about the last time you heard of something big happening in your department, if it was a retrograde intubation or an awake thoracotomy or whatever, you know, a thing you want to dream up that everyone's talking about in the hospital. Oh my God, this happened. Tom Cruise came to. Oh, that happens all the time. But if you think about that, think about how many people are in your team, how many people are in your hospital. How likely is it that you as a practitioner will be there for that one case? And how often will that case come around? And therefore, when we're talking about a tricky skill for those of us that aren't interventional radiologists, those of us that aren't vascular surgeons, to suddenly upskill and do quickly in the sickest patients, it's actually asking quite a bit of people. Now, I've done a number of Reboas, and I find it really hard to get the arterial line in. That's the hardest thing because these vessels are tiny when people are bleeding to death. It's easy peasy if I'm doing it in theatre for someone who's euvolemic, but it's really hard in this group. So for us, I think if we are getting to those patients early enough and if we are selecting those patients early enough, then I think it's still a feasible treatment for that small group of patients. But what I think the Reboa trial shows us is when we look at these global treatments and these things, it's not just the treatment. It's not that silver bullet that people have spoken about that's going to solve everything. It's about incorporating it into the patient's pathway at the right time for them with the right training for us and doing it the right way. And it all comes down to patient selection. And I think that's a really hard thing when we're talking about finding that elusive, marmot in West Hampstead. There aren't many there. There are far more on the mountain here. You aren't going to find them very often. So you've really got to look hard and you've got to be certain that you're doing it. And I think what one of the previous speakers said about having honourable intentions when you're doing a procedure, you've got to ask yourself, is this that right patient that I'm doing it in? And I think that's a complicated thing. So we can talk more about Reboa at the end or at the bar. The theme of shock is going to go on, but we're not just going to talk about hemorrhagic shock, because I'm sure you'll just get bored. Everyone in London bleeds to death. Well, some of them do, some of them don't. And this is where we're going to carry on to the next speaker. So I know some of us have spoken about blood before, and we talk about giving blood and blood being the thing and volume being the thing that patients need, and that chimes in with the physiology. But we've got to look at what fluid and what thing we're giving them. So the next speaker is the principal investigator of the SWIFT trial and is a consultant hematologist and is going to speak to us about the blood trials and our experience in London and around the world. So hand over to Laura.
Thank you very much. Can you hear me? If I fall off this podium, please take a picture, but don't share it on social media. And if I do get injured, I'm in safe hands. So I'm a consultant hematologist, so I'm not a paramedic. I'm not an anesthetist, so don't ask me difficult questions. I'm just the lab person behind the doors that causes you a lot of problems. But I work for the blood service, and the other half of the time I work for the hospital. So that gives me the luxury to understand the issues that the blood service has and your problems. So trying to bring them together has been probably one of the privileges in my job. And then the 8th day of the week, I spend some time doing research. So I'll share with you the whole blood journey. This is a journey, so there will be no conclusion of the UK. How did we reach to the whole blood? And it's a journey of so many organizations, and within those organizations, of so many people who have been part of it and have really guided us into the trial, which you might say may not have been the right ending, but I think it was the right way to conclude this journey. So I've called it the whole blood program, and within that you will see there were so many projects that we had to deliver, and I will share with you the results of those projects and how they all led to the design and the running of the study of whole blood in frontline trauma called SWIFT, and it's an acronym that I came up with, which I'm very proud of. So I will fast forward the evidence because I think you all know what have been the trials in blood transfusion and in trauma. But in 2015, the proper trial was published looking at different ratios of red cell, plasma and platelet, with the primary outcome being 24-hour mortality and 30-day mortality. There was absolutely no difference in the primary outcomes, and the trial was underpowered. The secondary outcome showed that death from exsanguination was better in the high ratio versus the 1:1:2 ratio, although this outcome was subjective. So you could argue that even that one, I would take it with a pinch of salt. Either way, this is what the UK guidelines very quickly published. This is the British Society for Hematology guideline on management of major bleeding and the National Institute for Health and Care Excellence, that for all trauma patients who come into hospital with bleeding, we must transfuse 1:1 ratio of red cell and plasma. And if NICE issues recommendation in the UK, I don't know how much you know about our system, we are obliged to follow, and we have to show evidence that we have complied with that evidence. And so in some recommendation, NICE also gives you financial incentives. So that's where you get your managers pushing you to do something because they're not getting their pounds. So that was fine. So by 2016, the London Air Ambulance approached me saying, well, hold on, we are already giving blood on board to these patients. So the recommendation should apply not just to patients who come into hospital, but also to patients who present outside hospital with trauma bleeding. And that was fair and square. So I said to Anne Weaver, who approached me then, well, you can have thawed plasma. You will meet that demand. But their argument was that, thank you very much for giving us the thawed plasma, but we don't have enough space in our vehicles. We have limited IV access to those patients. Some of them may have lost a limb. So which medication or blood product are we going to give first? So you're not making it easy for us. It does mean that we need to carry many boxes with many products, which is not ideal. But the most important part, I think, for me is, and I hear that happening now, that people try to give all the component at the scene of the accident instead of pushing these patients straight to the hospital, which is the place where they will get the ultimate care. So you want to shorten that time. So London then wanted whole blood because US had already implemented it. Norway had already started using whole blood despite the lack of evidence. So this is what we realized straight away, said, ooh, okay. Within our manufacturing processes, we use leukodepletion filters, and UK was the first country to introduce that because of variant CJD. And is a safety procedure that has been taken up by many other countries, and it was a good thing to do. The problem with leukodepletion filters that we use at the moment is that they remove 80% of your platelet. So what you end up with is a whole blood without platelet, or what I'm going to call from now on, red cell and plasma in one bag. So we turn to the London and say, well, you can have this product. It will fulfill your criteria, and we have a lot of data in the UK to show that it's safe because we use it for a certain group of patients. you can use this product, you get your red cell, your plasma, and you will comply with the guidelines. But no, they wanted whole blood. So then we agreed that, fair enough, we were aware that there were filters in the market, mainly by one supplier that can spare the platelet, but we had not validated those filters. And within the blood service, we operate under very tight and high standards to demonstrate that whatever we do, any minimal changes we make to the component, we do not compromise the basic standards of the quality. So this led to the whole blood program being initiated in 2016. And I can't believe that 7 years down the line, we still have not completed the program. But it takes time to do things properly and in a robust way. The first thing we agreed we will do is you can have your RCP or the red cell and plasma in one bag. Now, you will comply with the guidelines, but we want the London Air Ambulance to work with us, with the blood service, to collect some good data to move us to the next stage. Second, we agreed that we will evaluate the new filters to produce whole blood component that can then be used for future in hospitals in the UK. And the last project was to really put all this together to look at, can we design and plan a randomized controlled trial that will compare whole blood versus standard of care in the UK. So I will share results of key parts of this program, and then I will conclude with the SWIFT trial. For the SWIFT trial, I don't have any data to share, but I will update you on where we are with regards to recruitment. So the RCP study was an observational study. The primary objective was mainly logistics. Can the blood service deliver this component to the London Air Ambulance? Was the first one. And the second one is, considering that this component will only be given to one group of patients, we wanted to see what the wastage would be in the hospital, which is very important. When people come to donate blood, and in the UK we don't pay our donors, you are responsible to make sure you do not waste that precious donation. And the secondary outcome were clinical. We wanted to look at 24-hour and 30-day mortality of the red cell and plasma component versus standard of care, and I'll come to that in the next slide. And we really wanted to assess the advantages of giving a combined product versus separate product in pre-hospital setting, which were the reasons why the London Air Ambulance came to us. But we wanted to really document those advantages. And the last part is to look at safety of the red cell and plasma, because remember, in the red cell and plasma component, you have plasma. We were going to give group O RCP. That means you have anti-A and anti-B in the plasma. So you need to make sure that you do not cause any hemolytic transfusion reaction to patients who are non-group O. So the design of the study was the London Air Ambulance. We agreed that from October 2018 to October 2020, we'll switch from giving red cell transfusion only, which was what they were doing then, to giving RCP transfusion only. And we told the service to carry on doing exactly what they've been doing before. We did not change their practice or the criteria with regards to who to give this component to. And then our comparator arms were two arms. One was a retrospective arm. This was a red cell arm in London. We have collected very good data on patients who have received red cell transfusion only in the pre-hospital setting. And this is the timeline for that retrospective data. And the blood service demanded that we also have a prospective arm. And we were very well aware that there were services, pre-hospital services, in England that were giving red cell and plasma. And we were very lucky that they approached us and said, we want to be part of it. So they are your prospective comparator arm against the red cell and plasma. So the first one is the wastage. I haven't included the other primary objective, which was, can the blood service deliver the component to the hospital? Yes, they could. So they met all the criteria that we had set. And for any study, when you start, you do need to pre-specify what are you going to look for. And for wastage, these were the traffic light criteria that we agreed with regards to this component. So if you're wasting more than 30%, then I think we can't continue like this. And then if you're wasting less than 8%, then we said this is acceptable. And we took some of these numbers based on the current blood component wastage in the trauma setting. So Josephine was one of the biomedical scientists who did a PhD in this. And here is the wastage level. Within 2 to 3 months, the wastage of this component was 70%. And I started to get so many emails from the blood service, at which point I refused to respond to them. It was very painful to really deal with that. So first, very quickly, we made a decision. We cannot continue to give this component only to pre-hospital teams. So we decided to move it to A&E patient, to trauma patients in A&E who were bleeding. And that indeed had an effect on the wastage. But with any new intervention you implement in hospitals, you're dealing with a lot of people. You need to make sure you keep training colleagues. And also you need to change the way people do. People are used to getting red cell and thawed plasma. So even though this new component was available in the fridges, they were not picking it up because they were not aware. So what we did, we used our research fellows. We've got 24/7 trauma research fellows at the Royal London Hospital. So we use them to try and help us to get people to use the component in hospital. And indeed, that had the biggest impact on the wastage. But the wastage was still high. So at this point, we agreed that we will give this component to other patients who are bleeding in hospital outside trauma. And at this point, COVID hit, and we were not able to implement this because all the research resources, at least in the UK, were pooled towards COVID response. So we won't know what the impact is, but we have done a model. And if we were to implement that in the hospital, the wastage would have dropped to less than 5%. This is the clinical outcome data of the 3 arms. As you can see, red cell only arm, the red cell and thawed plasma or lyoplasma, and then the red cell and plasma component in one bag arm. And what I would like to draw attention to is time from injury to hospital arrival. As expected, the time to arrival to hospital was slightly longer outside London versus London. But the good thing was that for the 2 arms, for London Air Ambulance, they were quite similar. So the data demonstrate that we are looking at the same patients. And second, London had more penetrating injury than sites who were outside London, who had more blunt injury. And this data has been published and is free. Actually, you can access the paper. You don't have to pay. This is, I haven't included other information, but this is the adjusted mortality. And we looked at the association of the 2 arms with mortality. And the first thing I want to say is that indeed there were strong signals that if you give red cell and plasma, any forms of plasma, be that through thawed plasma, lyoplas, or RCP component, indeed the 24-hour mortality was better than if you give red cell only transfusion. Now, if you look at the 95% confidence for the RBC plus P arm, it has crossed the 1, so it was not significant. And there was a reason for that, because we went on to look at the interaction in the model between blunt and penetrating injury. And what we saw, to our surprise, that the effect with better outcome for red cell and plasma was due to, it was mainly in patients who had penetrating injury. We did not see this effect in patients who had blunt injury. And this is against what the Pampa trial has shown, and I think the Cryostat 2 trial also. So we don't understand what this means, and we do need to be very careful because this was still an observational study, but this was the data. There was no difference in 30-day mortality with regards to the association of these arms. So I'll move on to practical advantages. This is work done by Harriet Tucker, who was the other PhD student. She looked at recording 3 different teams who were experienced in delivering blood transfusion in pre-hospital setting. And she compared the 3 different arms, as you can see in red. One was giving 2 RCP unit, which was what London was doing. The second arm was 2 RBC plus 2 thawed plasma. And the third arm was 2 RBC plus 2 lyoplas. And they were all intervention that we were giving in England. And what Ariet went on to look at is these outcomes that you see on your right-hand side. Flow time, which was a time that was spent the moment you decided this patient needs blood transfusion to the moment when you completed administering that transfusion. And then the touch time, how much time you spend touching the component, etc. Number of steps, number of people, and number of components needed to complete the whole transfusion once the decision was made. And here are the results of the main outcomes. And you can see that when you give a combined component, indeed, it was superior with regards to time, number of resources, people you need, etc. But for me, the most surprising one was that giving 2 units of red cell and 2 lyoplas took 3 times longer than giving a combined component. And I don't know about here or in other countries, but lyoplas is more expensive than thawed plasma for us. So it's worth thinking about this data. What about the development of the new filters? I'm not sharing all the work that we've done because we did a very extensive laboratory work on that to look at the quality of the component. But what I would like to share with you is the platelet count, because we all understand what that is. And here are the results. So over time, even when you use the new filters that spare the platelet, your platelet count will go down. And you can see by day 21, they reach 50% of the baseline. So you've got to be aware that the whole blood you're getting doesn't have all the platelet that you have on the day 1. And also you need to be aware that no blood service will be able to supply you with fresh whole blood, i.e. 24-hour shelf life. So you do need to look at the risks and benefit of getting a longer shelf life of whole blood. Well, what about the design of the trial? So we wanted to look at the evidence. So we did a few systematic review, but I'll only share 4 of them with you. The first one was to look at what is the evidence that whole blood is better than standard of care in trauma patients who are bleeding. And this is work led by Rose Davenport, showing that there was absolutely no evidence. There was, at that time when we did the review, there was only 1 randomized control trial in US who had compared whole blood. And even that trial did not use a whole blood that we are talking about. They used more a modified whole blood. Second, we looked at outcome measures that are used in trauma studies that evaluate blood transfusion as an intervention. And even for mortality, I can tell you it was defined in 30 different ways. I mean, how can you get that wrong? So there's absolutely no standardization with regards to outcomes that we should measure in these trials. The other review we did is to look at if we were to give you red cell and plasma component in 1 bag or whole blood, we as a blood service need to define what is the safe anti-A and anti-B titer that we can give you that does not cause any harm to the patients who are non-group O. And this is a piece of work done by Josephine. And to our surprise, this has never been done. But we were able to show that at least what we were using in the UK were within the safe limit. And that's what we will continue for the whole blood. And the last one is, as I showed you, if you were to give whole blood only to 1 group of patients in any country, I can guarantee you, you will end up wasting it. Because we use it in London, and London is the biggest trauma center for us in England. And if they had such a high wastage, all other sites will have even higher wastage. So we looked at, okay, we do need to give this component to other patients in order to keep the wastage down. So we looked at the evidence of use of whole blood outside trauma. And I think I was very impressed with some of the data. They were mainly in cardiac surgery, and there were actually signals that giving whole blood was better than giving component. But please don't tell any cardiac surgeons, because they'll come on my door. And we just need to finish a trauma first, and then we can move to them. And then the last part we did was a survey. So this was led by Jason Smith and Ed Barnard. They surveyed all the pre-hospital services in England with regards to what are you doing now? Are you giving blood? Do you want us to introduce whole blood? And how would you like the component to be introduced? And the summary of this data shows that at the point when we did the survey, 90% of the services were already giving blood on board. So if you want to do any trial, you need to bear that in mind. So people have moved to a different stage, and you need to take that into account when you design the trial. And second, I think 80% of the services said that we would like to have whole blood, but we would also like to have good evidence. So that was very strong message to us. So I cannot carry on without mentioning the refill trial, because also time was just as we were designing the next trial, refill trial was published. This is a UK study in pre-hospital setting. I personally think was a good study. It's just that we had moved on with it and we didn't support it as much as we should have supported it. But it looked at comparing blood transfusion through red cell and lyoplase versus cell line resuscitation in pre-hospital setting. And here are the primary outcome, which was composite of episode mortality or failure to clear lactate. And there was no difference. And it was published and reported as a negative trial. But if you look on, I think it's table 3 in that publication, at the 3-hour mortality, there was 7% absolute difference in mortality in the blood transfusion arm. It missed the significance because the study was underpowered. But had it reached the number that it needed, maybe 600 patients, you would have seen that difference. And I have contacted the CI of refill trial because he's also part of the SWIFT trial, and asked him what was the 24-hour mortality in that trial. They were not supposed to put that out because it wasn't pre-specified in the protocol, which drives you nuts. You think you collect all this data and we can't publish them. But the 24-hour mortality was exactly the same as 3-hour mortality. Now, if I put it up to you guys, would you take a component that has 7% reduction in mortality at 24 hours forward in your clinical care? Raise your hand up if you say, yes, I would be very happy with that. Well, I would too, yeah. So it's just also how we report trials is very important. So everybody was saying, oh, why are you doing this trial? We need to stop giving blood to pre-hospital team. Why are we supporting them? Why are we pushing them to another level? But it's wrong. I think even refuel trial, be that it took 6 years to complete, it did show some evidence that giving blood is better than giving crystalloid. So before we designed the SWIFT trial, this is where we were. We had evaluated the red cell and plasma component. We were able to also look at the new filters. We showed that if you give a component for one group of patients, the wastage is going to be high. There are logistical benefits to giving combined component in pre-hospital setting versus separate component. When you compare RCP arm versus red cell and thawed arm, which I didn't share with you, there was no difference in outcome. So that's very reassuring for us. So whatever the SWIFT trial shows, if it shows that whole blood is not beneficial, I have promised the air ambulances that you will have RCP in one bag because of the logistical benefits. The clinical outcome for whole blood is absolutely non-existent, even though other countries have implemented this. And clinicians wanted us to produce high quality data before we implement whole blood. So this moves me very nicely to the SWIFT trial, which is a randomized control trial of pre-hospital whole blood transfusion versus standard of care in patients with life-threatening bleeding. Our primary research question will look to answer if pre-hospital whole blood transfusion is superior to standard of care in reducing composite of mortality or massive transfusion at 24 hours. I was very specific that this needs to be a superiority trial. We didn't want a non-inferiority trial because you can have the RCP component as far as I'm concerned, because for us to introduce whole blood, there will be so many changes we would need to make in the manufacturing unit that we do need to look at, is this cost-effective way of removing this important resource for other patients? And the secondary outcome is the usual cocktail that you will have in any trials. But what I want to put out or sort of pull out of the secondary outcome is the health economic evaluation that we will do. And the second one, we will also look at the implementation study. The implementation studies tend to happen usually after your phase 3 trial. So we want to look at what are the hurdles that we would need to overcome to implement whole blood in the whole country should the result of the trial show to be superior. This is the inclusion criteria, is a pragmatic trial. And like we did with RCP, we told services to carry on doing what they normally do. We did check their criteria for transfusing blood. Well, guess what? They were all the same because we like to copy each other. And the exclusion criteria are very simple. If you cannot give blood through intravenous or through your bones, then you can't recruit the patient. And second, if the patient has already told you that they don't want to get blood, then we would need to respect their wishes. And this is the trial design. What we've done is we've moved all the research activities away from the emergency services. So the randomization happens in the laboratory, in the transfusion laboratories. So when the team receives the boxes, they don't know what's in the box. And we have weighed the boxes for the intervention and the standard of care arm to make sure that they don't weigh differently, because you guys are quite smart. But the moment you open that box, that patient is randomized, so you cannot cheat. And people know that. So we try to make it as robust as possible. And patient in traumatic cardiac arrest will be treated separately. They will not be included in the main analysis because we know their outcome is different. And we saw in the previous study that 20 to 25% of patients you give blood to are in cardiac arrest. And don't get me started here with the London Air ambulances. Why they're giving blood to their patients? Anyhow, and this is a number of patients we're looking at, just under 850 patients to randomize. These are the 10 air ambulances in England that are taking part in the trial. None of them are currently randomizing, and the last one is MAGPAS, is due to come at the end of February. And we've just been working with international sites. Canada and New Zealand will also start recruitment in March. The other thing I would like to highlight is the funding model for this trial is not funded by usual funders for research, but is funded by the very organization that would like to really get the answer to this question. So the 10 charities you're seeing here are co-funding equally the trial with the National Blood Service, and the Ministry of Defence in the UK has also contributed to part of that funding, which is not as high as the other two partners. So it really shows that if you work with everyone, people would be very happy to support you, even financially. Here is a site update. As I said, 9 sites are currently recruiting. And I want to highlight here the number of sites we had to work in the 9 months. We've set up 9 sites, and it's heroic, honestly. 45 sites we had to work with, and 236 people we had to be that are directly involved with delivering this trial, because you have your transfusion laboratory, the research team who collecting the data, your pre-hospital team, and your trauma services. So it's a huge amount of work from the clinical trial unit to get this trial up and running. And we've learned so much about how you set up trial. And we've had so much enthusiasm. A lot of other services have approached us to want to take part in the trial, and we just can't support them because we need to be able to deliver the component for the sites. And here is some preliminary data from the January trial management group, where we are with recruitment. As you can see, London was the first to start. That's why, because I'm in London, so I had to make sure I had to show by example that I support this study. So just under 50% are from London, and the rest are from the other sites. And my last 2 slides are mainly acknowledgement. These are the people and the organization that supported the first part of the study, the red cell and plasma study, and the funders at the bottom, and of course the SWIFT trial, who is now completing the program. So thank you very much for your attention.
Thank you so much, Laura. I never realized that you knew that I was checking the way to the boxes. Um, so we've talked about hemorrhage, and we've talked about Reboa, and we've talked about the products that we give after that. But I think some of the other speakers, and I'm sort of thinking back to some of the hemorrhage, the circulation talks earlier today, and Sarah's stuff about the different types of shock and how complicated it can be to tell those apart. We also go to a lot of patients with polytrauma and mixed injuries. It would be nice and simple if the patient's just presented with one injury, but we can fill the blood, we can sort out the hemorrhage. That's plumbing. That's what surgeons do. But when we start bringing the brain into it, it gets a lot more complicated. And that's what my colleague Flora is going to talk to us about next.
Right, good afternoon, everybody. I'm hoping you can hear me at the back. Thank you very much for the introduction, John. Thank you for having me here today. I can assure you all that this is by far the most prestigious audience I've been with within the last 24 hours. So thank you for having me. I'm a consultant in emergency medicine at the Royal London. I'm also fortunate enough to be a consultant with London's Air Ambulance and have a particular interest in traumatic brain injury. I know that John's described how our session this evening is sort of having a running theme of shock throughout it. And for those who were here last year, I know that my colleagues and friends, Sammy, Zain and Robbie, left you with the notion of the importance of resuscitating both the brain and the heart if we are to make any progress in our sort of future potential survivors. So why am I here today talking about traumatic brain injury? And how does this fit in? Well, to start with, we know that TBI is a huge problem, a huge international problem with multiple calls for further knowledge and further research. We know that it's the most common cause of death or disability in under 40-year-olds in the UK. If we look at studies that have looked at Europe, 37% of their injury-related mortality is associated with traumatic brain injury. And in America, you can see that they're the equivalent of their TARN database. 50% of their trauma deaths are associated with a severe TBI. Gentlemen, I'm afraid it's the standard trauma picture. There are many more men versus women being affected by this, but these are huge numbers. And if we look at our own service, which is LAA, we go to more than 5 head injured patients with a GCS of 8 or less per week. If we look at the proportion that we transport to hospital with an isolated severe TBI, so excluding those that pronounce life extinct on scene, we're taking more than 1 a week. That excludes all of your polytrauma patients. And I suppose what I've found most incentivizing about this topic is that whilst we've seen improvements in injury-related mortality over the last 30 years, we have not seen the same improvements in the outcome of traumatic brain injury. Despite the same process changes that we've implemented, we have not seen the same improvements. So why? What is it that we don't yet know? How is it that we can potentially benefit these patients in the future? I want to talk a little bit about this because I think it's important. So we talked about the golden hour classically in trauma. As the time window within which we may be able to make interventions that might improve or impact on the physiology and the outcome for our patients. I would suggest that in the context of traumatic brain injury, we should perhaps be talking about the golden seconds to minutes, the hyperacute phase that occurs in that really early time following injury that may impact on outcome. The feeling that we have within our group is that by the time these patients get to hospital, the water's often bolted and too much time has passed. If we're to impact on their physiology and potentially their outcome to save every last brain cell, then perhaps it's in the really early phase that we need to be focusing. So I'm going to talk a little bit about, I hope, our experience within our system, and I appreciate that's unique to LAA, but I hope that it has some representation for others in the context of traumatic brain injury. And I'm going to talk about a little bit about the early pathophysiology. I'm going to speak specifically about some of the cardiovascular sequelae that we've seen in head injured patients, about shock in head injured patients and the clinical challenges that we're currently facing and talking about. So I'm sure everyone in the room is aware of this, but over the last however long, we've increasingly recognised that head injury or traumatic brain injury is not isolated to the head or the brain alone. It absolutely results in a multi-system effect. So there are some very clever people who are working out the impact of axonal stretch at the level of the axons within the brain and all the microcellular changes that happen with calcium influxes and how they might impact on those to perhaps stall some of those changes to help preserve some of that brain function. So that's happening within the skull itself. But beyond that, we also know from animal studies, particularly, and increasingly recognizing it amongst humans and our patients, is that if someone is hit hard enough on the head, they may well suffer a period of apnea, there's breathing, and they may be followed by a period of dysventilation. A phenomena that if you breathe for them and help to ventilate them, they absolutely can recover to a GCS of 15 and have a normal CT head scan and go home. We also know that head injury patients, by the time they get to hospital, will have shown a systemic inflammatory and so coagulopathy and pro-inflammatory response. And on top of all of that, we've got the cardiovascular features, which I suspect probably are more commonly associated with tachycardias, hypertension, presumed to be secondary to a catechismine type surge. But I don't think that's all that it is. So in the context of trauma, shock is probably most commonly associated with bleeding, hypovolemia, and spinal cord injury or neurogenic shock. It wasn't long ago that ATLS, it's about 2018 I think this was, that they were quoting that shock does not result from isolated brain injuries alone. And our experience has been slightly varied to that. So this is an example of any number actually, but this is an 81-year-old lady, just to put it into the clinical context, who our team attended, who was a very unfortunate pedestrian versus a motorbike. She was thrown quite some distance on scene. She was immediately unconscious, and the bystanders on scene could tell us that she was unconscious, but always breathing, but with some dysventilation. She had a reduced GCS of 4, she had unequal pupils. And following clinical examination, the feeling amongst the team was that she likely had a significant traumatic brain injury, the suspected subdural, possibly subarachnoid, possibly into parenchymal blood. They thought she had some left-sided rib fractures, a right-sided scapular fracture, and possibly associated rib fractures on the right side. They recognised that given the mechanism, she was at risk of intra-abdominal injuries and pelvic fracture, and that she had an obvious open left tib-fib fracture. These are her observations, and I'm sorry because it probably doesn't project well to the back, but I can just, what I want to do really is just draw your attention to, oh, no, not that, to the fact that she is, from the time that the team were with her, she is profoundly hypotensive. So with systolics of 59 over 45, 86 over 50, 77 over 51. She has an element of tachycardia. Her SATS trace is rarely there actually in those initial phases. By the time they get to hospital, she's got SATS of 99 to 100% picking up. But these low SATS are likely associated with an element of poor perfusion. Despite blood products on scene and all the other interventions that I'll come to, this lady remained hypotensive throughout her pre-hospital time. This is a not excellent, I can say that because I took it, echo of her. This is just on loop. This is on scene when she was profoundly shocked. And I think really the take home from this is that it shows globally inadequate systolic function, contractility. The other loops I'm not going to show you now, but I can tell you that the fast scan essentially that we did was negative for blood within her abdomen. So what do we do with that lady? Well, we gave her a blood transfusion because we couldn't be sure that she wasn't bleeding. We gave her an anaesthetic, we decompressed her chest, we treated her with hypertonic saline, we put an arterial line in, we ultrasounded her in order to try and help guide our clinical judgment and acumen as to what was driving that shock. And we escorted her to a major trauma centre where we pre-alerted the team that we thought that she may be bleeding, but we thought this may be driven by a significant head injury. Her outcome, what were her injuries? I know that's what we all wanted to know. So yes, she had some rib fractures. She had tibial fractures. She had a pelvic fracture with hematomas and a grade 2 splenic lac. She also had significant blood in her head, subarachnoid, particularly in cerebral contusions, associated with right skull and facial fractures. She'd clearly lost some blood, but she never went to theatre for bleeding. She had a bit of volume replacement within resus, but ultimately her medical management was for her brain injury. And very sadly, that's what she later died of several weeks later. So what do we do with this group of patients who are a real clinical challenge for us on scene to try and tease out what is driving this shock? And is that what we're seeing? Is this being driven by a severe TBI? And how do we best treat them? So we've done this is unpublished at the moment, we've done a retrospective observational cohort study with prospective collected data, combining data from a level 1 trauma centre and our own physician-led air ambulance service, which is LAA HEMS. And we looked to try and determine how frequently was this happening. Was this phenomena that we were describing within our clinical meetings really a thing? How often were we seeing patients with essentially physiological shock, but with only an isolated traumatic brain injury on further investigation? And what do those patients look like? And then to compare the treatment and the clinical outcomes with those who had what we described as cardiovascular dysfunction versus those who didn't. And we described cardiovascular dysfunction just from a pragmatic point of view, really, as someone who was concurrently tachycardic and hypotensive. And so we have a cohort of 168 patients with a median age of 46. 77% were male, which is probably, as you're aware, in keeping with the female-male ratio that we're currently seeing. These are a sick group of patients with a median ISS of 25, and 51% of them had a head AIS of 5. The 999 time to us being on scene the median was 31 minutes, but 1 in 4 of these patients were being attended by us within 20 minutes. So first observations within 20 minutes following injury. And we found that 20% of this cohort were physiologically shocked on our initial assessment. And within the LAA cohort specifically, 24% of them were shocked prior to RSI. This is just briefly showing the any differences or similarities between those that were the non-cardiovascular dysfunction group compared to those who were physiologically shocked. What you'll see is that there is no difference between age, sex, ISS, head IS, timings pre-hospital. The shocked group had a lower GCS, 3 versus 5. You can debate whether that's clinically significant. But on arrival to hospital, those with cardiovascular dysfunction had a significantly higher lactate and were more coagulopathic. So lactate is 6.1 compared to 2.4. In terms of pre-hospital treatment and outcome, the bits that I'd draw your attention to are in the pre-hospital phase, those patients who were shocked were more likely to receive blood products, and they had a higher 24-hour blood transfusion. And importantly, and perhaps unsurprisingly, they had almost a double mortality. This is just really describing the cohort of patients and looking. So the grey bars on the right are demonstrating those with cardiovascular dysfunction or shock. The black bars are those without. This graph on the left here just shows that this is a phenomena that impacts across all age groups. This is not a disease per se or phenomena of the elderly. It seems to be happening across all age groups. Mechanisms of injury associated with this. We saw it across the whole spectrum of blunt trauma, traumatic injuries, with the exception of very low injury mechanism of those that were essentially falling from standing, falling from less than 2 meters. We saw the cardiovascular dysfunction represented across all of the AIS groups. And interestingly, they had a significantly higher representation at both the lower AIS groups and, of course, the highest AIS groups. And when we looked at their CT findings, so are there any, could we see any correlation between where blood is sitting in these patients within their skull? Is there a way of predicting who may suffer shock? And actually no. We found that there was no difference no statistical difference in where blood was seated between extradural, subdural, subarachnoid, diffuse axonal injury between these two groups, other than a higher risk of hypoxic ischemic encephalopathy in the shocked cohort. In terms of outcome and mortality, the take home here really is that those who were shocked, unsurprisingly, had almost double mortality. But interestingly, those with an AIS of 5, so perhaps the sort of the severe end of the AIS spectrum, there was no difference between mortality in those that were shocked and those that weren't. So this perhaps is not, AIS is perhaps a not good predictor of those who are going to display this phenomena. And I think really importantly, there was no difference in our surviving group. There was no difference in the proportion between the groups who went home to their own homes or a nursing home statistically. And 22% of our survivors and who we managed to achieve GOS scores on went home neurologically intact from the shocked group. So perhaps where a prognosis of very poor outcome might previously have been attributed, we wonder whether or not there is some hope for some of this patient group. So I just want to talk a little bit about pathophysiology and how can we try to explain this phenomena of tachycardia, hypertension, physiological shock in an isolated TBI patient? Well, it's long been recognized, thanks to animal studies since the 1890s, that animals hit hard enough on the head will develop a shock response, stress response. So that's a tachycardia and a hypertension. And it took nearly 100 years to attribute that to a catecholamine surge. And here on the right, you can see a beautiful graph of peaks of adrenaline and noradrenaline within seconds of injury in these animal models. Does that happen in humans? Yes, we know that's well recognized. And we've demonstrated that by the time these patients get to hospital, their plasma catecholamine levels will correlate with their ISS and their GCS, so perhaps an element of severity. And actually, more than that, will go on to correlate with functional outcome and mortality. But I'd also like to float the fact that there's the potential impact of not just the systemic surge of catecholamines that these patients may suffer, but also the impact of locally released catecholamines, specifically noradrenaline, at the level of the heart itself, where it's there to innervate your cardiac myocytes. So for anyone who needs reminding, this is your rod-shaped cardiac myocyte in a Petri dish. This is it exposed to 30 minutes of noradrenaline, and this is it exposed to an hour of noradrenaline. And what you'll see is a super contracted state here and a really hyper-contracted state here. Take this into a human who sadly has died with evidence only of a head injury on post-mortem, and our forensic colleagues have found these bands of necrotic tissue within their myocardium on autopsy. And the suggestion being that the innervation of our cardiac myocytes by noradrenaline at the level of the myocardium causes this huge calcium influx due to excessive noradrenaline release that perhaps we see resulting in myocardial dysfunction in these patients. So this is really a hypothesis more than anything, but pulling together all the bits we've talked about. If we were to try and propose how patients with an isolated TBI can end up with a shocked state, what we know is that hit hard enough on the head, we know that it's likely multifactorial. Hit hard enough on the head, someone will be rendered apneic, which undoubtedly will lead them for a period of hypoxia, hypercarbia, acidosis, an environment that no heart likes to work in. In addition to that, we know that you will see surges of systemic catecholamines in these patients that will undoubtedly increase their systemic vascular resistance, increase their afterload, increase the myocardial oxygen demand against which a heart is trying to beat. In addition to that, there's the notion that there may be some impact of the catecholamines released locally to the myocardium itself, causing myocyte hypercontraction and cell death, and potentially impacting on your ability of your heart to pump normally, which is maybe part of what we're seeing on the scan that I showed you earlier. And we know that in addition to all of that, you've got a systemic inflammatory mediated response, which will undoubtedly play into a vasoplegic state over time. And so clinically, what we're detecting is we're seeing patients who, rather like the lady I described to you earlier, is having often swings in blood pressure, not in keeping with the patients we're used to recognizing who are hypovolemic, whose blood pressure decreases over time. But these are patients who are immensely labile in their blood pressure. We've seen changes on echo. And why does all of this matter? Well, because unless we have meaningful cardiac output, we can't possibly provide the cerebral perfusion and therefore the cerebral oxygenation that these patients are needing in order to perfuse their brain, oxygenate it, and allow for potentially optimal brain cell survival and outcome. So as a team, our current challenge is, in this area of patients, is recognizing this and trying to understand it really. I think we appreciate that it is a phenomena of sorts. A lot of the stuff that I've described is small numbers and is hypothetical in nature. But what we're trying to grapple with at the moment is how do we recognize these patients in the pre-hospital field? Does it matter? Is it important to? If it is, how are we going to do that? What do they look like? How do we best optimize those patients? How do we best treat it? Are blood products the correct answer for them? Sure, there's an element of coagulopathy, but actually are large volumes the right thing to treat these patients with who haven't necessarily lost large volumes of blood? How do we best optimize the cardiac output for these patients so that they can have some chance of perfusing their brain and oxygenating their brains going forward? So from a sort of internal system point of view at the moment, we are absolutely recognizing the impact and relevance of what I've termed here as the hyperacute phase, though those really early seconds to minutes and early part of that patient's journey following impact. And particularly in that, the role of dispatch to this. So the real value add of our colleagues who are on the desk in dispatch and listening into the 999 calls, able to help support paramedics and bystanders on scene, to open patients' airways, to help to recognize dysventilation, to help to breathe for those patients, and really try and optimize that early phase of care. We talk about sort of exquisite attention to detail from the earliest point of contact, and I think really that's about a desire to try and move the dial of where we're getting best care and target endpoints for these patients into the time frame that were perhaps golden minutes as opposed to the golden hour or hour and a half when they get to hospital that may or may not, but just may impact on outcome. And we've increasingly introduced the use of ultrasound scan to our practice in order to try and help clinicians because not just rely on their gestalt, which sure we value, but we also recognise its limitations. So we now introduced a guideline of sorts that describes the use of ultrasound to help us determine whether we think somebody is bleeding, whether we think that they have good cardiac contractility, but with poor systemic vascular resistance that may benefit from early vasopressor with some preload, or whether we've got patients who are showing poor cardiac contractility that would likely benefit from some preload and an early inotrope. So this is my last slide, but really in conclusion, we recognise that head injury is a big concern internationally, worldwide, I know, but particularly also within the trauma population that we're seeing, and are motivated certainly by the lack of improvement we've seen in the last 30 years. I suggest there's likely going to be no quick fix. I mean, we haven't managed that in 30 years, so I'd love to produce a silver bullet for these patients, but let's be realistic. But I do wonder whether improvement may come from precise pre-hospital management in that hyperacute phase, and really the importance, as I said, of the dispatch and bystanders in that patient's journey. Cardiovascular dysfunction as a thing is something that we're increasingly recognizing, and in our cohort is represented in, well, we found 24% of our patients prior to RSI in those severe TBI patients. And really, if we're to improve these patients' outcomes in the future, there's absolutely no doubt a need for better understanding of both the pathophysiology and perhaps ways in which we could target management going forward. Thank you.
Thank you, Flora. That was really good. So whilst Flora was cavorting with minor B-list celebs last night, our next speaker was at an award ceremony, and he was nominated for a leadership award. Unfortunately, he didn't get it. But what I said to him when he turned up at the train station a few hours ago, looking disappointed, is that, remember, Maverick didn't win any awards either. So our next speaker, going along with the theme of shock, and we've talked about the brain, we've talked about the circulation, but now we're going to talk about the pump and talk about our ambitions towards pre-hospital ECMO. And so Mamoon Abu Habsa is a ECMO consultant at Barts Health. He's worked for a number of air ambulances around the UK, and he's one of the leads for educating and trying to get monkeys like me to put pipes in people and press go.
Thank you, John. Thank you for that. I'll pay you back. For the next 30 minutes or so, I'll attempt to explore what we've done really over the last 5 or 6 years, and perhaps share some lessons that may be generalizable to your systems with regards to extracorporeal support. The interesting thing about extracorporeal support is we often refer to it as something new, or at least in the last 10 years, many of us went around treating it as new science. In 1976, a group of clinicians put patients on cardiopulmonary bypass and essentially with ECMO intent, protracted extracorporeal support intent. 38 of them, 16 survived. And that was a mixed group. That group was a group of trauma patients, some cardiogenic shock, post-cardiac arrest, post-myocardial infarction, and a couple of overdoses. And frankly, if we're to look at the groups that benefit the most from cardiovascular support today, extracorporeal mechanical cardiovascular support today, wouldn't choose a group vastly different, although until recently, trauma was somewhat controversial. We've heard from Flora earlier about the impact of brain injury on cardiovascular system. We've certainly come to know that a high burden of trauma can cause cardiovascular dysfunction. Indeed, we've put patients on cardiovascular support after high burden of trauma, and some of them have survived. But that's not what we're going to focus on. Today, we're fortunate to have better technology, more portable, and in addition to the Mackay system, there are others in the market. For the purpose of everyone getting on the same page, I won't dwell too much on the intricacies of extracorporeal support, but I'm just going to define a few basics that I have no doubt are familiar to many of you in the audience. In fact, I have no doubt many of you in the audience in the Big Sick have probably contributed to some of the papers that I'll be discussing. VV support, or veno-venous support, is essentially taking blood out of the venous system, oxygenating it, returning it to the venous system, used for primary respiratory failure. Veno-arterial support is taking blood out of the venous system back into the arterial system, used in cardiogenic shock, used in the context of extracorporeal support for cardiac arrest, otherwise known as extracorporeal cardiopulmonary resuscitation, and I'll refer to that as ECPR for the duration of this. When we talk about circuits, we're talking about, I beg your pardon. When we talk about circuits, we're talking about cannulae, we're talking about a pump that's spinning the blood, we're talking about the oxygenator, or otherwise referred to as lung, attached to a blender that ensures you've got access to oxygen, air mix, so and what we refer to as a sweet gas that help you clear your carbon dioxide, and, and then a return cannula that will take the blood back into whichever part of the system, and some monitoring. But the core components of the circuit are essentially your cannulae, your pump, your lung, and your and the connections between them. Chen's paper in 2008, I refer to in pretty much every ECPR talk because I still consider it a milestone or a benchmark paper. So Chen, many of you will be familiar with his work, looked at in-hospital cardiac arrest in very decent numbers in 2008 and the few years preceding that. So it was published in 2008. And what's really interesting about Chen's work is that because the patients were inpatients, he was able to institute extracorporeal support within the first 10 minutes. He was able to institute extracorporeal support within the first 10 minutes, but then went on to teach us that, or the decision to institute it was within the first 10 minutes. And people went on it. Those who didn't get a ROSC in 10 minutes, sorry, I think I made a fudge of that. Those who didn't get a ROSC within 10 minutes were commenced on extracorporeal support. But what he demonstrated, probably more than any other paper to date, is this beautiful link between the survivors and the time, and that kind of was sustained until the 60-minute point. So it taught us that we kind of need to get patients on within 60 minutes. It taught us that the sooner we do it was the better, and it taught us that it can result in improved survival that is sustained at 1 year post intervention, which is frankly quite impressive for a procedure that's meant to be life support and really a bridge. Of course, most of those patients went on to have primary cardiac interventions at a cardiac center, so one has to take that into account. Why am I referring to this? Well, because a few years of further work followed. I'm sure has been here and Alice has been here at some point, and they'll tell you about the hundreds of patients that have been done in France, from whom we've learned many, and I had the pleasure of working with them and indeed training under them. Now, we've learned who survived. We learned that you kind of want to be doing this on witness patients. We've learned since then that the survivors are more likely to be shockable rhythms, better in the younger, but most people now do it up to 65, if not 70. And we've derived some consensus guide. Shockable rhythms better than others. Primary cardiac etiology is probably best. And we've got international consensus guidelines to tell us how to do it, when to do it, and largely who to do it on for the context of refractory cardiac arrest. And those are the guidelines. And if we look at the papers in the preceding, these were 2021. If we look at the papers in the preceding sort of 10 years, most of which converged on age 70 or thereabout, witness arrest being absolutely essential, shorter low flow time being important, end tidal CO2 having significance in predicting survivals, intermittent ROSC is great, signs of life at any point being great. And that's more or less what we look for. Are you at a undifferentiated patient in whom you don't really know much about? Gonna know whether they have aortic valve incompetence? I doubt that, so we will move on. Since then, since then, a lot of work has been published. Most of you have heard about the work in Minnesota, small population. Regardless of our personal thoughts, preferences on a big truck doing ECMO at the roadside, or people jumping out of ambulances doing it at the roadside, or indeed facilitating a system whereby it can be done within a very, very brief few minutes of the onset of cardiac arrest at the roadside. And I'll at least go on to talk about our own experience with that. The reality is people were cannulated and established on full flow in the Minnesota system faster than any other system in the world, and one cannot ignore that. And while we may not be able to, due to complexities within our respective systems, copy paste that, one has to think what system would look similar within the respective systems we work within. Inception, I may come across as I'm being somewhat critical here, and it's absolutely vital. I'm not actually. It's absolutely vital to consider the negative studies when we're talking about something that potentially will change the way we resuscitate people for a very long time, at a very high cost burden, at a very high training burden, at a very significant governance burden and potentially reshaping our networks as they exist with the intent of saving many more lives. But Inception did teach us that actually introduced ad hoc, introduced in centers at low volume, like the work we listened to earlier, will probably have issues. Nonetheless, it informed the subsequent design of what looks like a very impressive system for ECPR delivery in Holland today. So ultimately, it was a fantastic feasibility study that informed subsequent system design, and primary HEMS are delivering ECPR in Holland today. Another potentially another negative study, registry paper from France, the country that has done more ECPR out of hospital than any other country to date. And this was published a couple of years ago. This essentially is a registry study comparing 12,500 versus 500 patients in the ECPR group, showing a survival that was more or less the same. Now, I found that, and I say that with the greatest respect, because to do that study on 13,000 patients would have taken a huge amount of people's efforts. I found it slightly less helpful for one reason, or one predominant reason, is there's probably, like I said, greater experience in ECPR in France, in Paris today, than any other system in the world. They've done upwards of 700-800 patients at the last check. And therefore, it is impossible, if not, it's highly unlikely, if not impossible, for the first cohort of patients, and these guys started ahead of everyone else, 2012, 2013, it's not impossible for the rapid deployment of ECPR and indeed the low flow time and everything else within the system, learning how to deal with these patients, to be the same in 2022 or 2020 as it was back then. So as a result of that, within those 500, you have some subgroups of very low flow time, very low complication rates, and indeed much better survival. And within those, you also have some patients that were, by necessity, starting this in 2012, 2013, some may have viewed this as a somewhat maverick procedure. Back then, quite frankly, patients were going on at 60 minutes, 70 minutes, 90 minutes, 120 minutes in some cases. There were survivors, but you almost at that point had to prove a survival in a presumed dead patient to justify the existence of the procedure. So to then lump all of those patients together in one big cohort and call that the composite outcome of the entire ECPR group would be somewhat unfair. And that's my issue with this. And I think it's yet important to visit a negative paper to understand implications for our own system. Why do it at the roadside at all? I mean, this is a procedure that first had its success demonstrated in the in-hospital setting and went on to be done in and out of hospital for a few years. Why did we bother with the pre-hospital? Well, we spent preceding pre-2013 in France, pre-2019 in London, we spent the preceding 20 years or so in educating or learning alongside our pre-hospital peers, paramedics, advanced paramedics, indeed physicians, saying the medical cardiac arrest, it is unlikely that arrival at a hospital setting is likely to make a difference. Very few centers accept people with mechanical CPR straight onto cath lab. I acknowledge they exist, but very few do. And therefore, by and large, rightly or wrongly, the patients are arriving in the emergency department probably at the 45 to 60-minute mark following cardiac arrest, when frankly it was game, set, and match. And therefore, to actually have access to those patients at all, we had to go to them. While other work continued in the background, that probably now tells us that if you've not had a ROSC by your third or fourth shock, that's probably going to be a sustained refractory cardiac arrest type scenario. And that's probably the time that we can think about interfering. But anyway, that was the original intent. It was because for some, or for the odd patient, we might have received them at 30 minutes, but for the majority, we were going to receive them after 60 minutes. Even allowing a very fast procedure of time of 10, 15 minutes, the prospect of getting the patient on full cardiac flow at least one that is going to resuscitate their brain, preserve their brain and heart, is going to be quite low, at least in the system as it was. So what did we do? Well, we have the privilege of having a service that has successfully transferred complex hospital interventions to the roadside repeatedly, safely, and in a very robustly governed way, from RSIs to thoracotomies, REVOAs. So the first thing to say is this work is only possible because of the work of some true greats that who preceded us and who did get that work done. And therefore we followed the same model. We ensured that the competence and expertise to deliver that complex procedure was there. We designed a protocol that involved revisiting the procedure to ensure every step that is done in the hospital can necessarily be done in the out-of-hospital setting, and whether it requires modification. We decided to study the process that we're working through, and indeed study explore the feasibility in a formal way to inform any further planning, owing to the complexity, education burden, and cost burden of that intervention. This took, in preparation, pretty much most of 2016 through 2019. We kicked off in 2019 and had some success. It was going very smoothly, and then COVID struck. Our intention was to explore the proportion of patients of a predetermined sample of 6 that we can successfully institute this procedure on within a viable time of 60 minutes, and if at all possible, within 30 minutes. I will go into appraise the significance of the 30 minutes when I describe the system in greater detail. We deployed the same assets, but obviously we modified our equipment to something not far off what we would have used to retrieve a patient on VV or VA, except we used the primary response car. And we plugged ourselves into the London Ambulance System service dispatch system, as would occur for our trauma dispatches, except the difference here was the advanced paramedic practitioners who had the specialist role ordinarily of responding to the cardiac arrests and indeed self-selecting them for their team to optimize concentrate experience, optimize outcome, etc. It made perfect sense for them to select the cardiac arrest for us. Now that took a few minutes, and we arrived on scene at anywhere between 7 and 30 minutes across the 5 patients. In fact, across all the patients, including the ones that we didn't institute for other reasons. We prioritize femoral access upon arrival. So all of our resources, our thinking, our training, our rehearsal, our simulation, everyone's objective, from the paramedic to the ECMO consultants to the HEMS consultant that was coordinating the scene, everyone's objective was an early screening to determine if that patient has an overt contraindication for extracorporeal support, something that was pre-rehearsed and very much checklist determined. Within a minute of arriving on scene, one of us would be scrubbed and getting femoral access. And I mean literally a minute. And that meant that we had femoral access very rapidly. Now we have to identify here, declare, call it what you wish, that we operated that model with 2 competent cannulators, if not ECMO consultants. And that was important because we were keen to test the feasibility in the context of an already competent team, with the aspiration of being able to get other members within the team to that level of competence. And the confounders, even for the purposes of feasibility, were many. And therefore, it made sense to see if someone who's already done numerous cannulations and is somewhat of an expert at the procedure can do so. And we were able to do that. Unfortunately, the study was interrupted by COVID, so we went on to resume in 2022, early part of 23 actually. By the time we're over the effects of COVID and pressures in elective care and intensive care, etc., and went on to do 5 patients in total. At which point we were interrupted by circuit availability and other logistic challenges that led us to close the study at 5. We're in the process of doing so now, and you should see it written up with the granular detail downstream. The femoral access cannulation weren't challenges. In terms of other sort of information I can report now, our procedures took somewhere between, our low flow time was somewhere between 32 and 62 minutes, so very healthy. When we're able to get to the patients on scene quickly, we were able to do them very quickly indeed. Now, I'd like to talk about the 30 minutes and the whole sub 30. You'll recall the chart that I said to you, why bother doing it at the roadside at all? If within an urban environment like London, where there is a high concentration of hospitals, patients, and several centers that are capable of delivering via ECMO, and therefore receiving those patients, and potentially with potential expansion in such a system, if we could be in a car and respond to that patient and put them on ECMO at the roadside, have them on full flow in 30 minutes, that means we've got 30 minutes to spare to convey a lot of patients if we were to work alongside our pre-hospital colleagues, our ambulance service colleagues, I should say, on a very clear protocol of X number of shocks, automated CPR, package, convey, go to X, Y, and Z hospital. And that would give us potentially the opportunity to scale up very rapidly the number of patients who are accessing this in somewhat equitable fashion, rather than being dependent on the one day of the week or the X day or X hour we're able to offer the service. And that made more sense, in fact, from a service effectiveness point of view, than at least in isolation seeking to train a high volume of consultants in ECPR. And so it seems. Now, what does the system look like today? We'll probably end up with a hybrid system. We are currently, let's say, capability developing our ECPR capacity within the London Air Ambulance, and indeed we are supporting several centres in as a collaborative pan-London effort in having several centres, 5 centres, capable of receiving patients on ECPR. And one hopes by the second half of this year that patients will be able to have access to this technique in a much more regular fashion than it is today. We've taken too long, potentially, from 2016, 2019 to get started, and from 2019 to today. But to build a sustainable, robustly governed capability really does require the hard yards, let alone something where the number of clinicians in every country who are either interested in it or able to deliver it are so few. And therefore, it made perfect sense for the few of us who are invested in this today to really refocus our efforts into scaling up the knowledge and the competence and working alongside colleagues so that we're able to deliver this in equitable fashion, at least across one city, and then perhaps attempt to replicate the model. That city I'm referring to is, in this instance, is London, due to our geographical presence and the high volume of population in a small area. I want to talk through the technique very quickly because I think that's probably useful. It's really not rocket science. When I'm referring to the femoral access, I'm referring to a 7 French or 8 French needle and sheath that go into the femoral artery and femoral vein respectively. If the patient was to have a ROSC, then it's no big deal. That's one outline, one central line standard of care in cardiac arrest. We package, we convey, taken to a cardiac center, no biggie. If the patient were not to, and they were to meet the criteria, then it's really quite simple. A long wire, dilate, and cannulate. That's it. Now, one must treat it with a significant element of respect because these are 15 French, more likely 17 French arterial cannula, 23, 25, maybe 27 French venous. These are host pipes. These are bigger than some of the chest drains that most people would put in. And therefore, considering that cardiac arrest, even after 3 shocks, has still got a prospect of survival. It might be 1% after 3 shocks, it might be lower. Doing an intervention that ultimately dissects an artery or lacerates a vein will inevitably kill the patient in that context. And if nothing else, it would set us back. It would be very unfortunate for the patient, but it would set the whole process back. And therefore, although I'm really simplifying the procedure because it really is not much different to inserting a hemodialysis line, just a little bit bigger, and one needs to be probably more meticulous in every step. It's not much more than that. How did we revise the system? What did we do different? How did we reinvent the wheel? Well, we have a group of clinicians who have trained on ECMO in different centers, and some have trained on a hybrid technique, some have trained on an open technique, some have trained on an entirely percutaneous technique. For the purposes of in-hospital ECMO delivery within BARTS, the standard technique is closed, percutaneous, and indeed unified to be a 2-stage. So access sheath first, long wires, dilatation. So it made perfect sense to keep that technique when we're doing the procedure in an unfamiliar environment out of the hospital setting. And even if not unfamiliar for some of us, certainly an environment that has its own hazards and complexities. How have we modified the technique, and where is the wheel reinvention? Well, I think it's now largely acceptable, and I'd love to hear from any of the audience who are involved in ECMO in resuscitative purposes or otherwise. It's now largely acceptable with the quality of dilators and indeed the shape of the cannula to do single-stage dilatation. So certainly for a 17 French cannula. So these are seconds, minutes that could be gained probably at a without any excess risk burden. The caveat is whatever you're going to do in resuscitative setting, ensure that is what you're doing in your elective or your VVs. VVs I consider to be, I mean, sure, VV ECMO can be quite sick patients, but in general, you do have more time. Even the cardiogenic shock ones, you probably have more time than the ECPR. I think I'm correct in saying that I think every single one of us in this system would consider an identical technique in every single setting, and therefore, if we agree to change the technique, we all change the technique. It makes measurement, it makes governance, it makes everything easier, and that's probably the single most useful thing that I can say actually. From an interaction with colleagues in the London Ambulance Service, well, we very much viewed the whole thing as one team, but we had to be out of each other's way. The team from London Ambulance Service, specifically the advanced paramedic practitioners, had a very good pit crew model for managing cardiac arrest, a lot of standardization, and some marginal improvements in outcome of such patients, actually, and that couldn't be ignored. So we separated ourselves. We work within the groin concurrently, and they focus on we work below the groin, and they focus on resuscitating the patient, and with a clear designation of a nominee to sustain the communication across that imaginary barrier as such. And yes, you might be competing for space, but it kind of works. By the time you've put by the time you've prepped and draped and secured your area, etc., you can and you will be very much task focused. Obviously, elements such as delivery of shocks, suspension and chest compressions, if at all needed, and we aim for no pauses really until commencement of ECPR, other than for other than for delivery of shocks, obviously. See, sort of a little bit of synchrony is required for the purpose of the delivery of shocks whilst the first few shocks are being delivered. But otherwise, it worked really well. How did we educate the team? What are the options? Well, this is what ELSO, I'm sure most of you will be familiar with ELSO. Let's consider this an overarching global education and governance organization for extracorporeal support. That's what an ELSO practitioner, clinician practitioner looks like. So a combination of didactic learning, sim lab, and some bedside experience, all of which is stipulated. Of course, that's designed for VV, VA, and ECLS. And the curriculum ends up being quite extensive, but nothing, nothing frankly unreasonable. You kind of needed a little bit about background of ECMO. Okay, sure, there's some historical context which may or may not have sort of absolute necessity for achieving the desired knowledge and competence level. But there's essentials such as, sort of base fundamentals of the pumps and the VV, ECMO physiology, ECMO physics, troubleshooting, and all the rest of it. But is detailed knowledge of VV weaning necessary if our ambition is to scale up education for a life-saving intervention that 99.9% of patients today are not receiving? Probably not. So there was a consensus paper. Some of the authors work within our system, and the beauty of it is it actually incorporated authors from numerous systems, including some of whom who are well represented in ELSO, that came up with a set of competencies which largely mirror what we have set out within our system, both combining theory, applied skills, sim lab, competency sign-off, and where necessary, clinical experience at the bedside within our own, I don't think colder cases is the correct expression, our own routine delivery of non-resuscitative VV and VA. And that program kicked off in mid-January, and you can get feedback over a few drinks from John about that. Program, broadly speaking, looks like a combination of pre-course e-learning, some skills labs, some bedside training, assessment, retraining once we iteratively redesign the system. Now, we were in a zone where we were patching pre-hospital expertise with in-hospital expertise to deliver an advanced procedure. It now needs to be owned by the pre-hospital experts, and therefore there will be iterations, there will be design. Sometimes when we give these talks and we dwell on what a kit dump looks like and what it takes for me or John or anyone else to be able to have both femoral vessels accessed within a couple of minutes, actually it takes a lot more than an individual skill. And then everyone being on the same page, the prep and draping and the kit dump and everything being done for you is what makes it happen. And therefore the whole team needs to have that shared objective, shared understanding of what the barriers are to completion and what it will take to do. And therefore there will be iterative change within the system. And then hopefully a few months down the line, we will have a launch of the system with some proctorship of some description. And then hopefully it'll be a sustained capability every single day of the week for the population of the city we serve. The governance system, frankly, I could apply that model to what we do in pre-hospital care. I could apply that model to what we do within our ordinary ECMO service. Governance is something that's probably one of the better things that we're currently doing in the NHS. And I don't think any of that will come as a surprise to you. It needs to be multi-layer. It needs to be individual level, at collective level, at organizational level, and it needs to have some peer-to-peer component. If you're going to deliver something advanced, extraordinary out of the hospital setting, or even in the hospital setting, you need to adhere to the absolute highest standards of governance. I think that's obvious to all. The overall capability design, okay, none of the fundamentals of capability development are missing here. But if you ask me what we spent the 3-4 years doing, it's building the networks and the connections and uncommon connections across the system to be able to get the guidelines in place and approved, get education package sorted out, get the e-learning sort of loaded onto our system, connect 3-4 organizations together on a new technique that most would be unfamiliar with, and many who were familiar with are averse to. And that's what took years. Is an in-hospital, is a primary in-hospital delivery system feasible? Hypothetically speaking, it may be that some of you or many of you in the audience don't see yourself delivering this out of hospital ever. Of course it is. But you need to work very closely, very collaboratively with your EMS providers to ensure those patients arrive at your center. And in any town or city with a population size, I hypothesize, over 500,000, you probably have sufficient cases to sustain a service at the local hospital. That's a fairly extreme statement, but then again, I am at the big six, so I have to. I hadn't pre-rehearsed that, so I hope I don't live to regret it. But, but more to the point, just roll back 30, 40 years, and filtration was a technique that patients were either flown to or it was flown to them. And it's probably only 40, 50 years ago that was the case. I honestly don't see extracorporeal support 5 years down the line being anywhere near as rare as it is now. We just have a very tough sort of slow upstroke of the initial curve just because the education burden is high. But we must conquer that. And it's for that reason that we are at pains now, not to be clinically delivering, but to working with colleagues to develop our system. Hopefully that decision will be vindicated downstream. I don't think it's a question of do we perform ECPR for cardiac arrest? I think who do we perform it on? How do we do it safely, equitably, and efficiently under the current strains on health services? Thank you, guys.
Thank you very much. Thank you for sitting so quietly and attentively through that. I don't think I have many questions I can answer, but the rest of the team can. So are there any questions from the audience, and do we have a roving mic?
Yeah.
I was just wondering about, John was saying that when he does a reboa, for example, the artery is very small because of the blood loss. Have you thought of maybe changing to a hybrid technique like the French ones, where you actually see the vessel and then you can use it as for ECPR as well as for reboa in the same kind of technique, same kind of teaching?
Okay. Thank you for that. The first thing I'll say is the very first technique I learned for the purpose of resuscitative extracorporeal support was the open technique. Indeed, with the guys in France. Now that we have the opportunity to deliver we have the scientific justification to do it earlier and the infrastructure to do it sooner. And it's no different than any other patients you encounter in cardiac arrest in the emergency department, where femoral line and femoral venous and arterial access are pretty straightforward in the first 5-10 minutes. I honestly don't think.
What about for the
Dr.
trauma?
Singer, I'll come to trauma in a second. Dr. Singer, my colleague, Ben Singer, who many of you will be familiar with, and indeed he's the powerhouse spearheading this project, often says that the patients in whom the arteries are so constricted, either because they're so far downstream in a medical cardiac arrest, or they've had such enormous doses of adrenergic support, or otherwise, are probably self-selecting patients to have a particularly poor outcome. And indeed, when they did do them with open technique, with surgical assistance or whatever way, in a hospital setting, they wanted to do quite badly. For the trauma patients, the phase that the patients that we have given VA support to is bleeding control has established, volume resuscitation has, at least by and large, been 75% established, and the patient is hopefully, if and when the system works well, and this is a continually learning system, the patient is on a moderate dose of cardiovascular support, or if they're not, at least they're not so severely constricted that we can't cannulate them. So in the latter VA cases we've done, certainly the most recent, cannulating the vessels hasn't been a challenge. Yeah.
Thank you for your speech. I'm from the Netherlands, and I'm a HEMS doctor involved also in the on-scene trial where we performed an ECMO on scene. The study is still going on, but so far we noticed that almost 10% of the patients are not really accessible by putting a line in because of their anatomy, because of their BMI, all these things. So there is a large number, a significant number which are not accessible for ECMO, I think.
Okay, thanks for that. Well, I mean, I fully respect your experience this far. What sort of patient volumes have you encountered thus far? And more importantly, how early are you managing to get to them? Because I think that matters. I think
Yeah, in the study, we are there allowed to put a line in the wire after 20 minutes. So in the European resuscitation schemes, they are in block 3, 4, 5, something. So they had adrenaline, they had fluid, and they're doing some cardiac massage.
And how are you tackling those, with open technique or with hyper technique?
Echo, ultrasound.
I beg your pardon?
With the ultrasound.
Oh yeah, but so yeah, well, when we talk about percutaneous technique, it's obviously we're referring to ultrasound guided technique. No, sorry, my question, perhaps I wasn't very clear. I apologize. How are you tackling the ones who you're unable to do percutaneously with ultrasound guidance? Are you then opening the groin, or how are you?
No, we stop them. We stop the
You
cannulation.
stop together, yeah. And that's 10% of the patients.
Yeah, it's
Well, I wouldn't
estimation.
say that we've done sufficient volume out of hospital to encounter those. And perhaps when we do start doing a higher volume out of hospital, we re-encounter that. But in general, a patient within the first 15, 20 minutes of cardiac arrest, being a challenge to cannulate both sets of femorals is not something I've encountered. But hey, listen, we work in different settings and different probably environmental considerations. So this is an area where we're only just beginning to learn the opportunity and the challenge.
Okay, thank you.
Any other questions? Gonna get my calories burnt before the cheese.
Sorry, thank you for your presentation. I think we more or less all work in systems that are under tremendous human and financial stresses. Regarding the primary outcome of eCPR so far, how is addressed the financial and human cost on our systems?
John, I didn't hear the latter part of the question.
My question is how much for such an output so far, an outcome of ECMO, out of hospital ECMO, how much cost and how much human availability is involved in the practice, and how much weight it puts on our system so far?
Superb question. Superb question. I'll summarize it to you. Today within our system, there are 2 or 3 doctors, and this is a very well established, as you've heard from Flora and indeed John, a very well established 30+ year pre-hospital care service. And even then within that system, we have 3, 4 doctors who would be able to perform that on their own or lead a team. That's not equitable. And therefore, we have diverted those resources into trebling that number to be able to offer something that looks like a sustainable solution to offer the service. So we're right now putting all of so we've paused, we've completed sub 30, we'll write it up, hopefully you guys will see it in the next couple of months. And we've concentrated our resources on education and scaling up to be able to do this every day in the hours that someone has any prospect of receiving bystander CPR. You'll hear some often say, you don't need eCPR services overnight because nobody gets bystander CPR overnight. Obviously, that's an exaggeration, but many cardiac arrests happen in the home and while people are asleep, and they're less likely to be detected. So at least in the hours of light, we hope to be able to offer that. And it's for that reason we have focused our resources and assets, human and otherwise, to make that happen.
Thank you very much for your great presentation. As you stated, or you suggested, as a caseload to have a city more than 500,000 people. So from your experience, for a small country like Switzerland, where there isn't any city as big as 500,000, what would you suggest for country like Switzerland, how to start?
An aeromedical response an aeromedical response, but you won't be able to cover every part of the country, and that's just the basis of the medicine we do. Like I have no doubt a patient in some city, in some country may have a primary myocardial infarction and maybe 3-4 hours away from a primary cath lab center. So we won't be able to tackle everything. But I would say that if you believe that this procedure with really good identification, prediction, all the cognitive aids available can be done within 10 to 15 minutes of an expert team arriving, if you take that as a realistic prospect or even target, then that means, to my simple mind, you can probably offer this service to any geography that's within a 30-minute flight time, provided good selection is done, if not wider. And I believe that's what my Dutch colleagues are doing. And if there's someone here from Holland, I would love to hear about the experience. I can't see, it's all dark. Oh, fantastic.
Yeah, sorry, not from Holland, but my question adds on to the second to last question. In your presentation, you showed like you go out with 2 ECMO consultants to those cases. Just staffing wise, how is that done? What are you doing on the other time?
That was
Are you in
purely
the
for sub
clinic?
30 for the feasibility study.
Okay.
So the system is now being designed to operate within our conventional model. So a ECPR competent HEMS consultant with an experienced HEMS paramedic being deployed by an aircraft that is used to deploying across the capital, that would deploy the assets where the patients will be treated on scene, and then obviously conveyance post ECPR is easy. You could do it by land, you could do it by any means available. So that would the 2 HEMS consultant model, call it an extra degree of caution otherwise, during the feasibility study. That was purely for sub 30. But you can't set up a system that needs 2 ECMO consultants when probably have about 40 of them in the whole UK, to be honest. If that, yeah.
Thank you very much. Now, I'm sure there are probably more questions, but we are running short of time. So thank you very much.
Thank you.
That was amazing. So thank you for your patience. So I think one of the great things about a conference like this is that now we're going to go on to a social evening with some drinks and some cheese, a lot of cheese. And I'll remind you of that tomorrow. But the conversations will continue, and please feel free to approach any one of us, and please make these conversations carry on. Patrick, I believe, is going to give us some information on the latest about what has happened to the cows and the cheese. Is he still there at the back? Have we lost Patrick? Has he fallen into the fondue? We can. I think they're just going to grab him from outside. We can take one more question if anyone wants to ask Laura or Flora a question, not me. Yeah.
With regards to the cardiac dysfunction, I was just presumably we're talking about a cytokine storm that essentially does a cardiac kind of stunning. I guess the question is do we have any data as to how long that stunning lasts on the ones that survive? Because they're young people, they're 40 years old. So
Yeah.
they should be...
It's a really good question. To my knowledge, the answer is no. I think we're still trying to really piece together the which elements of all the contributing factors are playing the greatest part and at what point in that patient's journey. And we see patients who, for example, this is very anecdotal, but who, for example, will be showing that cardiovascular dysfunction, who will initially respond to some preload and then stop responding to preload. We see patients who may respond to some preload and then may respond to some inotrope or vasopressor, and then that will change and actually it becomes meaningless. So we continue to provide phenylephrine or metaraminol, and actually whilst you've got a response initially, you're no longer getting one now, and that could be because all of their receptors are saturated. But I suspect that every element of the the sort of multifactorial parts I spoke about are having their effect over time, reaching a peak and then resolving, reaching a peak and then resolving. And actually where we catch our patient in that is really challenging to know. And I mean, I would love to determine which of those are the key drivers to the kind of the poor cardiac output that we're seeing. Is it the systemic catecholamine response? Is it at some point the pump failure that we're seeing? But because without really understanding that, we can't possibly target how we're going to manage it. So my point really from all of that is that we recognize there is a challenge here for us, and you know how we respond to it is not going to be easy. But I mean, all thoughts welcome now and over drinks. But you know, I think that if we're ever to try and improve that patient group, who you are absolutely correctly identify are young and some are surviving, this is not a group that are all dying, then I think we've got some work to do.
Thank you, Flora. Patrick. He's been rescued from the cheese.
Okay. So all the evidence-based medicine stuff is finished for today night. Is it correct? Good. Fondue is not evidence-based. It's just a tradition here in Switzerland. The first one signed up yesterday was, sorry, forgot already the name. At 7:29, Christian Maschmann. Is he here? Oh, okay. You are the first one who signed up. You got free fondue for tonight. Okay. Next up, we will meet each other about 8 o'clock, a little bit before, a little bit after, when 150 people's walking at the same time in the room. It will be probably a mess. Sit wherever you want. What's next for your jackets? If you take your jackets in a fondue stübli, they will smell until you reach home. You can let the jackets here, let it in our hotel or just in the garderobe. We have one. But the clothes that you will wear this night, they will smell of the cheese. Further introduction will follow up, and then we show how you can, what our tradition is and how we will proceed. Good.
Should we go to the bar then?
Yes.
Yes. So we've spoken about all the types of shock. Let's go upstairs and have some cheese shock.